Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. It is now my pleasure to introduce today's presenters. Linda Lansing is the Senior Vice President for Operations and Clinical Services for Surgical Care Affiliates. A nurse by background, Linda has over 40 years of experience in the healthcare sector, with a focus on the areas of nephrology, ambulatory surgery, and pediatrics. Linda has spoken extensively on the topics of clinical leadership, development, and continuous quality improvement processes, and is a member of the ASC Board of Directors. Michelle George is Vice President of Clinical Services with Surgical Care Affiliates. She provides clinical quality support and survey readiness assistance to the SCA ambulatory surgery centers located on the West Coast and to the company's surgical hospital division. Michelle has over 30 years of experience as a registered nurse. She has worked in various areas of nursing, including critical care, emergency and trauma, and surgical services. Michelle has served in multiple hospital and ambulatory surgical center leadership roles, served on professional advisory boards, as affiliate faculty to nursing program, and professional speaker to professional and state healthcare organizations. She has authored various nursing journal articles and been contributing author to a healthcare textbook. Michelle completed a Master's in Nursing Administration program at San Diego State University and holds a Certified Administrator Surgery Center certification. It is now my pleasure to turn the floor over to Linda to begin today's presentation.
Well, thank you very much, Kathy. Good morning or good afternoon to everyone participating in the call today. Michelle and I are very excited to be with you today to speak with you about creating and using a safe surgery checklist, a subject that's both very topical and extremely important in regards to ensuring patient safety. If we can turn to slide 2, what we'd like to do today is to go over 4 key items related to a safe surgery checklist. First, we'd like to do an overview of the history of checklists and provide you with some of the most current thoughts on checklists and checklist usage. Second, we'd like to review the regulatory and accreditation requirements for use of the safe surgery checklist. Third, we'd like to talk about some tips and guidance that you can use to develop a safe surgery checklist for your center or facility. And fourth, we'd like to share with you some experience that we've had and that others have had with checklist implementation. And then finally, as Kathy mentioned, we'll have some time for questions. So Kathy, if we could move to slide 3. Really what I'd like to do is start with just an overview of the origin of checklists on a whole. I think for most of us, checklists are really a part of our life. We use them every day just to get the pieces of our life accomplished in an orderly way. And for those of us who are nurses, I think our to-do lists are a critical component of who we are. And checklists for us, just from a practical and personal point of view, really are memory aids, and they really help us make sure that we've got done everything that we really want to get accomplished on every given day or time period. Interestingly, the origins of checklists being used in technical and a professional way really drive to the aviation industry, and it started in the 1930s. For any of you who are aware of the trajectory of the development of airplanes, that was a period of time in the United States where technology for an airplane just really rapidly ramped up, and the airplanes themselves just started to evolve in a very, very complex way. And interestingly, many of the people who were building the airplanes really began to realize that the technology of the plane itself might perhaps be a bit too complicated for the pilots. And interestingly, another observation that they made was that their experience showed that people with the most experience were not always the ones who had the best results in learning or using a new plane. Frequently, they would use as test pilots the most senior and experienced pilots, and they found out that their results in using new technology were frequently not as good as the results that were obtained by a brand new pilot who was much more open to coaching and guidance about how to use the equipment. And so basically they started taking those thought processes and looking at them and seeing what could they do to ensure that a pilot would not miss critical steps in preparing and using the airplane. And so that's when they really started focusing in on checklist development. And their main focus in developing a checklist was to ensure that they set the checklist up in a way that the mistake could be corrected or the defect could be corrected before it was actually used or a mistake happened. And it was pretty clear from looking now back at that time in the industry that these checklists really did drive improvement, and the use of checklists really spawned a lot of the modern federal agencies that we still have now in place, the FAA and the NTSB. So it's interesting that this really came about because complexity of an airplane started to exceed the competence of the pilot. So if we could go ahead and turn to slide 4, what I'd like to do is to go ahead and to give you some general thoughts from Atul Gawande, who is really considered the checklist expert here in the United States and in many cases across the world. And he wrote a pretty critical book several years ago called the Checklist Manifesto. And Gawande is a surgeon. He's also an author. And he really has focused most of his work on dealing with extreme complexity as it relates to process. And he's particularly interested in looking at processes that are both complex and routine. And I think that's one of the things that we're going to hear as we go along as being a key component here, is that there is that combination of complexity and routineness that has to be managed. And he really has a pretty simple solution. He just says you need to have a checklist for every complex routine. He really spends a lot of time focusing on the negative perceptions that checklists have, mostly that, and this is his direct words, that you're using them because you're dumb, and that technically competent people shouldn't need to use one. There's that general thought process out there. And his argument is that, people on a whole find themselves in challenging situations no matter what their skill level is, and that checklists can really help anyone who finds himself in a challenging position. And that's what most of us are. We're in challenging situations in the OR each and every day. He also views them as a cognitive net that defends us against failure, and I think that's a really interesting concept. And so in his book, he really asks us to consider why, when checklists are used with such good results in the aviation industry, why do we see such a lukewarm reception to using them in medicine? And I think he has some very interesting thoughts about all of this. And I think the first thing he really discusses in depth is the professional code of conduct. So anyone who is in a profession really does operate by a specific code of conduct, and he sees that there's really 3 key parts of that. That you're selfless, that you place the needs of others above yours, that you have skill, that you aim for excellence in regards to skill and knowledge, and trustworthiness, that as a professional we're responsible for our personal behavior when we're interacting with others. He also notes that aviators add another dimension to all of this, and they really look at discipline, and they think it's exceptionally important that you use prudence and you use prudent procedures when you work with others. Now, Gawande goes on to bring up the fact that in medicine, there's also an additional component that's in the Code of Conduct, and that is autonomy. And, you know, his thought is that medicine really does focus in on autonomy of the individual, particularly the physician. And this is really in direct opposition to discipline, which is what aviators are looking at. And so really he asks us, in this current medical environment where things are becoming increasingly more complex, is it really autonomy? Is that really what we want to focus in on? And so I think that's a very interesting viewpoint of checklists. So if we can go ahead and turn to slide 5. So again, why use a checklist? I think key things here are the more complex the procedure is, the more opportunities there are to miss the critical steps. And checklists work because they point out missed steps or problems that have been overlooked, particularly when we are extremely familiar with the procedure. And no matter how expert we are, a well-designed checklist has been proven to improve outcomes, and it's just really, really the right thing to do. So if we could turn our attention to slide 6, what I'd like to do next is just review some of the current literature on safe surgical checklist impact. I went through and I looked at literature from the end of 2011, all of 2012, and now through 2013. And if you remember, you know, we have some new CMS quality reporting guidelines that ask us to go ahead and to use a safe surgery checklist in our ASCs. And so there's been a lot of focus in on this over that period of time as the regulation rolled out and as we all prepared to go ahead and implement the checklist, and as we reported our usage just most recently a few months ago. And so if you look at all the literature, there's some interesting thoughts that are coming out about usage, patient outcomes and communication, and what the impact actually is and what it hinges on. And really, I think most of the literature continues to reiterate that that checklists have really been successfully adapted in a wide variety of settings and countries. So I think that's the good news about it. When they look at the pieces of the checklist that continue to be problematic, a lot of the literature says that the third phase is the phase in which checklists are most frequently incomplete. Also, they are beginning to see in the literature that steps that are directly related to the timeout components themselves, that those can be missed. I thought this next piece was very interesting, and they said that they are starting to see that there is a high compliance with items on a checklist that are already part of an established policy. And if it's a new item that's added to the checklist that's not part of the established policy, that there is much lower compliance. So that's kind of interesting. That speaks a lot to both culture and to learning. You know, if you look at a lot of the work that people like Covey have done and other learning experts, they really say it takes a while to go ahead and to change behavior, and also that significant behavior changes need to be driven by culture changes. And so that kind of ties all together with what we're seeing here, is that if it's something we've always done and it's on the checklist, we seem to want to do it, and if it's something new that we're added, the compliance is much less. They also have seen in some literature that the adoption rates are stronger with nurses and anesthesiologists versus surgeons. And one thing that's come out pretty significantly across all the literature is that customization and training is critical to the adoption rates. Now, if you look at outcomes and communication, definitely they've seen that there's increased detection of patient safety hazards, decrease of surgical complications, improved communications, and that it does seem to be a quote-unquote promising intervention for decreasing patient morbidity and mortality. And finally, the literature is starting to reflect that the impact of a checklist really hinges on how you implement the checklist, and do you understand the how and the why of what needs to be done. And I will go ahead, and when we send out the information following this webinar, I will go ahead and ask Kathy to include a really nice article that's out there now from the BMJ Quality and Safety Online Journal that was just published in June of this year about surgical checklists, a systematic review of impacts. It's just a really nice summary article. And for those of you who have physicians that really like to have evidence and data, it really is a nice tool for you to use to have the discussion about why is a checklist necessary. So next, I will go ahead and turn things over to Michelle, who will go ahead and go through with you the regulatory and accreditation requirements. Michelle.
Thank you, Linda. Well, hello, everyone. So as Linda mentioned, I'm going to walk you through some of the requirements of both from our regulatory standpoint, but also from the accreditation perspective from Joint Commission and AAAHC. So most of you know that this summer, we actually did our first attestation in terms of the use of the Safe Surgery Checklist. And literally it was a yes or no attestation by going into the QualityNet website. And literally they asked us if we used the checklist at any point during the year, the calendar year of 2012. And there was a lot of flexibility in what that checklist could look like. And as we go through the call, you're going to know that there are a number of different professional organizations who have developed and made recommendations about what that checklist design could actually look like. So we're not required to use any particular design, and indeed, many of those same professional organizations recommend that we actually design it for the our unique service lines and our unique settings. At this time, the no answer did not actually incur any type of financial penalty for our centers. However, most of you know that any time you are not reporting that you're completely compliant or 100% with anything, that there literally is a public consequence to that. So we're in that day and age where not only is the consumer, but also our competitors are looking at our performance and those types of information that we're reporting, and there could be a public relations or a local community implication for that. So certainly want to be able to report yes in the most strong fashion there. At this time, when a CMS surveyor or maybe a state surveyor on their behalf comes out to do a Medicare surveyor for us, they're not actually doing any type of an inquiry or validation into our checklist utilization. Is there a checklist? How are we using it? That today is not part of a Medicare survey. The next thing I want to walk through with this is any time that there is a CMS requirement, we're pretty used to there being a delay or a change in the date. And the Safe Surgery Checklist regulations is really no different. So as we look ahead, what we're most likely going to see in the calendar year of 2016 is a movement to alter the collection date and the submission periods for that Safe Surgery Checklist utilization and our ASC facility volumes, which is also a piece of that same reporting. The data collection would be for the calendar year occurring 2 years prior to the payment determination. So let me walk through that a little bit more because it might be a little bit confusing. I know it was for me when I first read it. So the data submission period would be expanded basically from July 1 through August 15 to January 1 to August 15 in the year prior to the payment determination. So a little further clarity around that. So for example, in the 2016 payment determination period, the data collection period would literally be from the date of service January 1 of 14 through December 31st of 14. Now the data submission period, which is a little bit different, would be from the period of January 1, 2015 through August 15th of that same year. So a few changes to put on your calendar and watch. If we could look at the next slide together, what I'd like to talk to us now about is the conditions for coverage requirement. So the Code for Federal Regulations section actually has some accepted procedures that we need to be able to follow to avoid surgical errors. So there's really 3 pieces here. The first one is a pre-procedure verification process to make sure that all the relevant documentation and related information is available. It's correctly identified, we match the patient, and that we are consistent with the procedure for that patient, and the ASC's clinical staff in terms of what we're expecting to be performed. And what that literally means is pulling out that patient's signed informed consent and using that as part of that pre-procedure verification process. Also required is the marking of the intended procedure site by the physician who will be performing the procedure or another member of the surgical team, so that it is not unambiguously clear. So what that means is literally those that are performing the procedure need to be involved in the intended procedure site. It means that the pre-op nurse cannot be the person who puts a marking on that site for us. The third piece of this is the timeout. The timeout needs to occur before starting a procedure to confirm that the correct patient, the correct site, and the correct procedure have all been identified, and that the required documents and equipment are available and ready for use. So those are the three elements for the conditions for federal regulations that need to be met in order for us to be compliant on that front. Now, if we look at slide number 9 together, so remember what I said earlier about the design of your safe surgery checklist? There are three elements that, when you're designing it, that you have to make sure is part of your process. It has to address the effective communication and the safe surgery practices in each of 3 perioperative periods. The first one is prior to administering anesthesia. So in other words, before induction, certain elements have to be addressed. The second one is prior to the skin incision. The third one is prior to the patient leaving the operating room. Now, depending on the design of your checklist, this could be a pretty short list. And ideally, from Gawande's perspective, remember, we're trying to simplify a very complex process. So if you think about the WHO checklist, which is just one of several examples that are out there for us, there are about 22 elements total on that entire checklist. And they're divided among the pre-induction, prior to skin incision, and then the last few are before the patient leaves the operating room. So those are the elements that we have to make sure that are part of any one of our safe surgery checklists in order to meet the Medicare requirements. Let's look at the next slide together and begin to talk about their accreditation requirements. So the first organization we want to look at is the Joint Commission. So it really goes back to the universal protocol defined by Joint Commission, and there are 3 different standards there. One is to conduct a pre-procedure verification process. The second one is to mark the procedure site, and the third one is a timeout. It's performed immediately prior to starting the procedure. Now, you notice that there's a lot of overlap between what Medicare standards say and Joint Commission says. The one piece that I want to point out is that immediately prior to starting the procedure is a key piece to the Joint Commission standards. So that means that that timeout literally has to be done immediately prior to the skin incision or the start of the procedure if it's not a skin incision type of procedure. So that definitely means that the timeout cannot occur and then the team leaves the room, for example, the physician going out to do a surgical scrub and then returning to the room. So immediately prior is the standout here. Let's look at the next slide together to begin to talk about the AAA requirements. So with AAA, you're going to see a lot of similarity here. One is that there's a process to identify or designate the surgical procedure that's to be performed, and also the identification of the surgical site, and it involves the patient in that process. So this basically gets to the pre-induction. The patient, if the patient's going to be participating, that patient has to be awake in order to participate. The person performing the procedure has to mark the site in the instance of AAA. So that does not allow it for it to be delegated to any other member of the surgical team. Now, there are a few exceptions, and actually AAA outlines those. And the one example they use is the tooth extraction, that there could be a mark done by the radiograph or a dental diagram for those. And there may be a few other procedures that this would be applicable to. The second element of meeting AAA requirements is that it needs to be performed immediately prior to beginning the procedure. The entire operating team verifies the patient's identification, addresses the intended procedure and the correct surgical site, and again, looks at all equipment that's routinely needed for this type of procedure, making sure that it's immediately available. And this standard also brings in the requirement to look at implantable devices that might be intended for use for this patient. And all of those must be immediately available in the operating room. So in other words, when you're doing a timeout, you're checking those items at the same time, which could include expiration dates and maybe the right implant as being a piece of that. So it means that they have to already be in the room and that the circulator cannot run out and get those after the procedure is started. The provider that's performing the procedure is personally responsible for ensuring that all aspects of this verification have been satisfactorily completed prior to beginning. And that goes back to the surgeon really being the lead on that team. At this time, I'd like to take it back to Linda, who's going to talk about actually how to develop a good safe surgery checklist.
Well, thank you, Michelle. And if we can turn our attention to slide 12, I think one of the things that at our organization, Surgical Care Affiliates, that we've really been changing our thoughts on over the last year is checklist customization. And if you remember back to the opening where I talked about an overview of checklists, a lot of the literature is really saying that one of the things that's really critical to successful implementation is customization. And I will have to say that perhaps in rolling out the checklist, to meet the quality reporting guidance, we may have been a little too literal in asking our teams to use just a standard checklist. And now really what we know is that success definitely hinges on customization. So what I'd like to do now is just run through a series of points and tips and information that you can use if you choose, like us, to go ahead and to move forward and to start with checklist customization. So first on slide 12, what we have is a checklist that many, many of us have seen. It's really where the origins of a lot of the publicly disseminated checklists come from, and this is from the World Health Organization, and it meets those three key phases that Michelle talked about before induction of anesthesia, before skin incision, and before the patient leaves the operating room. Now, if you can turn your attention to slide 13, this is another sample checklist, and this comes from AORN. I really like this checklist. As you can see, it is color-coded, and it says what requirements come from the World Health Organization, what relates back to the Joint Commission's Universal Protocol, what relates back to the National Safety Patient Goals, and what are things that are common to both Joint Commission and the World Health Organization. This is an updated checklist, and it was disseminated in June of 2013, so this is kind of the latest thinking that's out there. So if you can turn your attention now to slide 14, what I'd really like to do is to just review some thoughts and guidance on checklist development. And again, we're really of the mindset now that customizing a checklist is something that we absolutely must do for a variety of reasons. And I think here, once again, Gawande's guidance on checklist development is really a great place to start. This comes directly from his book, and we have that reference here in the deck if you have not yet seen it. So really, he says there's three components that you should really consider when you're developing a checklist. First, do you have clear, concise objectives for your checklist? Second, from a drafting point of view, have you considered a key list of things when you're actually putting the checklist together? And finally, did you do some validation before you implemented the checklist? And so that is really what his thought process is. So from a development point of view, the things that he is really focusing in on is making sure that the checklists are not overly detailed, because he really views that an overly detailed checklist results in uselessness, and that the checklist itself becomes so unwieldy that it's not used because teammates aren't going to use something that's so difficult to implement. And he also finds that if the checklist is set up in a way that it gets in the way of getting things done, then people aren't going to use it. And particularly if it's slowing people down. And for those of us who are in the ASC setting where efficiency and effectiveness in regards to moving our physicians in and out is one of our selling points, it would be problematic if we're putting something together that really gets in the way of everybody effectively doing their work. And really what he believes is that by having a really usable checklist to apply to a task, that you're going to free up brain space. And I thought that was a very interesting concept, because he said, if we are free in the moment to make sure that the task was done by using the checklist instead of having to remember the next step, then we're going to free up brain space that's going to allow us to go react more quickly to any kind of problem that we encounter. And so that right there is a very important concept. So from a development point of view, he asks us to ask if the checklist includes the critical safety steps that are most likely to be missed. That's really what the checklist is for. And are the items not adequately checked for by another mechanism? So if you already have a process in place that's tried and true and working well for you about checking an item that currently sits on your checklist, then perhaps you should consider taking it off, because duplication of documentation or activity always causes more mistakes. He also says that it's important for us to make sure that the item is actually actionable with a specific response. And can the items be affected by the use of the checklist? So do you have a checklist that's really going to drive something that's meaningful? From a drafting point of view, I think the first point is one that we have had to learn the hard way, is does the flow of the checklist utilize breaks in the workflow? Because if you're asking people to insert something new into their day-to-day processes and it doesn't fit in easily from a timing point of view, then more than likely it's not going to get done. And that's one of the pieces that we're starting to have more and more conversations with our teammates, is how do you use the checklist and does it fit normally into the flow of your work? You know, he talks about simple language. Are the titles really clear? Does it look uncluttered? Does it fit on one page? And he even goes on to give guidance about using color and what type of type to use. You know, is it dark text on a light background versus light text on a dark background? You know, are there fewer than 10 pause points? So in his book, he goes into this a little bit more deeply, and I think those are really good guidelines for drafting a checklist. And finally, his thought is that you really need to have a validation period before you implement the checklist. And have you trialed the checklist with the frontline users? You know, buy-in is extremely important, and I think Michelle will talk a bit about buy-in during the implementation section of this call. And it is important that everybody feels like their voice has been heard and that they have input into how something is going to be injected into their workflow. And really, does this ensure that the errors are detected at a time when they can still be corrected? And that's really what the whole entire goal here is, to go ahead and to catch and correct an error before it happens. And if your checklist is set up in an order that you would have already done the task before you're verifying it on the checklist, then you've lost your opportunity for the correction, and that's what this is about. So, did you go ahead and determine if the checklist can be completed in a reasonably brief period of time? And again, that just continues to flow with that thought process of making sure that it fits into the workflow. And he also goes on to say that you actually should practice it multiple times. Put the checklist out there, you know, use it in an actual room, see how it worked, and then get feedback from everybody to say, I think maybe if we did this at this time, it would work better. Maybe we need to move this up. This actual trialing is really critically important, and that's something that we are starting to focus more and more on. So if you can turn your attention to slide 15, I've included a couple of other tools for you, and I'm not going to go through all the detail, but these come from Safe Surgery 2015, the South Carolina project that was the initial pilot from Safe Surgery org that went on with the Harvard School of Public Health. And they have some great documents on their website that drive to a frequently asked question document that talks about checklist modification and some general recommendations. And I think the couple of things that is a little bit different in here, or additive to what Gawande says, is that they want to make sure that the checklist meant to be read out loud without reliance on memory. Does every person in the room have the opportunity to say something before the skin incision? You know, will there be an opportunity for the nurses in the text to discuss their concerns about the patient? You know, will the surgeon ask the entire team to speak up? That's very, very important, and one of the things that we've been focusing a lot on in our company about empowering people to communicate and to speak up. And before the patient leaves the OR, will the team discuss what could have been done better, which drives to the whole concept of quality improvement. So some interesting additional thoughts there. And if you turn to your attention to slide 16, the Safe Surgery 2015 South Carolina also has a checklist modification guide, and they give you some key tips here that you should really look at. So a lot of good information that's out and about that you can use to go ahead and to both develop and, more importantly, customize your checklist. So finally, if you'll look at slide 17, this gives you a nice overview of the resources that we have identified that are out there. Great resources from WHO and from safesurgery.org, including modifiable templates and templates that can be used like for endoscopy centers. So again, driving to that customization. AORN, as we saw their updated checklist from 2013, they have a lot of nice information, and they have toolkits and practice resources on their sites that augment a lot of this work that they've done on safe surgery checklists, which combines both WHO and the Joint Commission Universal Protocol. ASCA, our professional organization, has nice information on their Connect site. The Joint Commission has lots of information in regards to the Universal Protocol and a lot of nice information on their sites. There's Gawande's book, and then there is the site from Safe Surgery 2015 South Carolina, which has those resources that I just referenced. So a lot of information out there, and I would say, again, one of the things that has been a great learning for us is that if we don't customize the checklist to the center or the setting and ensure that there is full buy-in, that it's very difficult to have a successful implementation. So now I'd like to turn things back to Michelle, who's going to share some thoughts on implementing a safe surgery checklist. Michelle.
Thank you, Linda. So as Linda was saying, really the work happens and begins on the development side where you're engaging everyone. When it comes to implementation, really some of those key steps are equally important. One, on the implementation side, we need to be able to engage actively our key stakeholders, which could be a variety of folks, including all members of the clinical team, our nurses, our techs across the spectrum, our physicians, and our anesthesia providers, because remember, they're a piece of that as well. We need to make sure that we've developed clear tools and processes to be able to support the implementation. This could be in the way of toolkits, it could be in the way of policies, it could be training tools as well. And if we want this to be part of our everyday work and to happen in a clear way, we need to be equally clear about the expectations for individual accountability. We need to literally mark it and make it part of our culture. So earlier Linda said that it needed to be able to be implemented within a short period of time. And when you read the article that we're going to send out along with the deck in about a week or so, what you're going to see is they've identified some timing. Literally, they recommend that it would, if you have a simple checklist with key elements, all driven from patient safety perspective, that it would take about 1 minute per section. And remember, there are only 3 required sections, so literally across time, it would only add about 3 minutes of time to complete the entire checklist. The other thing about making it part of our culture is remember that if one team member speaks up, it could be a physician, it could be a nurse, it could be a tech, it could be any member of that team. If they were to question the procedure, ask more about the equipment, to speak up in any way about a misstep or a concern they might have, literally when it's part of your culture, everything stops and the problem is addressed and fixed prior to moving forward. So that's ideally when you know that you've got the best implementation piece. So let's look at the next slide together and begin to talk about how we engage our key stakeholders. Because the studies show that really the lack of engagement in the development And as you revise that checklist and make it customized for your particular facility, it's really the #1 reason that you have poor pull-through on the implementation side of the checklist. So make sure that you're including all members of your team in the development and also in the implementation of that checklist. Figure out who your key physicians are. So it might be someone who's in a lead role, a medical director, a chief of staff, someone with that title. But also keep in mind, and we all know this, that we have some physicians who are also influencers, title aside. So I would want to target both those in an official leadership position, but also those who people listen to help understand and champion the process for a better pull-through on that. The other thing is that we know is that we really get better results on implementation when people understand not just what we're doing, but the real why we're doing. And Gawande actually has some very clear thoughts on this. First of all, the studies that have been completed at a number of organizations show that with a checklist, we literally do see improvement. The very first checklist that was rolled out wasn't about safe surgery. It was about preventing infections in the ICU. And literally, it was a very simple checklist, 5 points on it solely. And over time, what they found out is through study is that they were able to decrease the infection rate in the ICU by 2/3. That's pretty significant. Now, let's talk a little bit about what we are seeing in terms of the surgery setting. First of all, we know through studies that we have about a 3 to 17% complication rate for surgical procedures. And they include things like wrong patient, wrong procedure, wrong site. Frequently we see things in that 17% around anesthesia equipment-related issues, unanticipated blood loss, retained surgical items fall into that, and then simply the lack of available equipment has created some complications as well. So when you think about the checklist and you relate it back to why, then that list, all of those things, the potential for those could be reduced by using a very simple and straightforward checklist. Now, Linda had mentioned earlier a little bit about autonomy, and she had spoken to it really being in conflict, autonomy versus discipline. And what Gawande goes on to say is that absolute respect for autonomy may actually interfere with good patient care. So what he's saying here is that there has to be a balance, because there does have to be a leader in the room, which is typically that surgeon. However, if you turn over complete autonomy to the surgeon, and that will vary from surgeon to surgeon, room to room, that literally you could be compromising the standardization of the processes that you want to be able to. And Linda also mentioned this earlier, is that as healthcare becomes more complex, with more regulations, more sophisticated equipment, and as we do more sophisticated procedures actually in our outpatient settings, that complexity is going up and up, and what we really need to do is to respond with ever simpler measures, and that the safe surgery checklist is really a simple strategy to simplify and standardize a very complex and evolving phenomena. Now, when you're going to have a successful implementation, one of the things that you need to do is to agree ahead on terms of what that commitment looks like, and really to sell it before you actually roll it out in any fashion. So once you've identified your physician champion, ask them to engage with their colleagues and really to look for support throughout the process. What you want to know is basically know the answer and where people stand on this before you begin your trial or your full implementation. And ultimately, over time, to determine your ultimate success with the implementation, you need to be able to track your usage and to report the successes on that at your MEC, your MACs, your governing board, and other physician staff meetings, and also your teammate meetings, because remember, this is broader than just the physician. It literally is the entire team. So when you have a fully engaged team, particularly when you've targeted some of your key stakeholders, it's going to be a much simpler implementation process with a lot better pull-through. Let's look at the next slide together and begin to talk about some of the tools and the processes that are really important. Now, Linda mentioned earlier that a validation of your checklist was important. And what you want to do is to trial it. Trial it with a particular service line, a small team. This is really that opportunity to refine the list. What you do want to do is make sure that it matches the workflow. So anytime that the checklist elements and the workflow order don't match, then you lend yourself to the strong opportunity of skipping a key element, because people don't work backwards, right? We work in an orderly fashion forward. This is also a time when you can identify some errors and fix those before a broader rollout. The other thing you want to do is, not only when you're making these changes and setting up your retrial, you want to make sure that the elements that are on that checklist really go back to the key purposes of a checklist itself. And to remind you, those, when it comes to a safe surgery checklist, are really to increase the detection of safety hazards, to decrease the surgical complication rate, and to increase communication among the OR team members. The other thing is, it's important to model the uses of the checklist in a very detailed way, not only for the folks to understand how to use it, but for them to be able to understand the why. And this can be done in a variety of ways. Frequently, toolkits are a way of rolling out a checklist. A toolkit can be made up of a variety of different things. It could be a policy, it could be a white paper, it could be a frequently asked questions sheet. It actually could include some videos. So for example, if you're looking for a perfect timeout where the entire team is engaged and they're using that consent, they're using the patient's record, and they're using the checklist as an interactive component of the timeout, then videoing that and having the team watch that is a very good way to focus in on some of those key steps and what they really look like. The other thing is flow diagrams help the team a lot, because people really want to know, what do I do next? And anytime you can lay things out in a stepwise fashion, it provides more clarity, and you're better apt to have compliance with that. And the other thing I want to say during your trial is make sure that you've kept it simple. You know, don't add too many items, because it becomes burdensome. Your team will tend to try to skip over pieces of it, and you never know what they're going to skip. It could be something that is very much the #1 safety item that you want to address. Let's look at slide number 21 together and begin to talk about personal accountability, because it really does come down to every individual understanding what they need to do, but actually doing it. And the way to get that accomplished is to clearly set those expectations. People need to know what it means to be a top-level performer. You know, how do you deliver results? What does that technical competency look like? And how does that align with your company's values? At Surgical Care Affiliates, we literally tie all of these activities back to our values of clinical excellence and service excellence. And it really is a good way to have the conversation with the teammates so that they understand, what does it look like and what is my role in this. And pay for performance speaks loudly. So when you're sitting down to talk about the last year, and if you have a teammate who shortcuts, doesn't use the consent, really doesn't demonstrate the technical competency that you're looking for, not only should you be having these conversations all the time, but this is the time where it really needs to be addressed in terms of a payment piece. Throughout all of your conversations, you need to be very clear on the expectations of the checklist use. You know, as a teammate, you cannot work to improve results if you don't perform as a top performer. And as a leader, you have to say what that top performer looks like. And if you're not going to act as a top performer, either as a leader or as a teammate, you're not going to be delivering the clinical results that you ultimately want for, or shooting for. Another thing is set the pace, okay? The leader needs to be reserving those timeouts and addressing with the teammate when those are not at the level that you've set the expectations out for. Look and see how the checklist is being used. If the pull-through is good, then you see the teammate actually reading from that checklist as they go step by step. When the checklist is laying over in a pile of papers on the counter and it gets addressed afterwards, after the procedure's already begun, then that's not the implementation that you're shooting for. And every conversation really needs to start with clinical quality. That's the why. You know, connect it back to the purpose. It's all about patient safety and preventing healthcare harm. And it would be very difficult for any teammate or physician to argue that this wasn't the right cause. And this is what we do in healthcare. Let's talk about the culture of patient safety by looking at this next slide together. One of the things that's important for our team is to really see the picture, to create that vision, and that's what the leader does. The physician leaders, the clinical leaders, the administrative leaders, we have the responsibility to paint the picture, talk in terms of healthcare harm, not doing a checklist, okay? It's about preventing healthcare harm ultimately. And good is not good enough because one surgical burn, one wrong site surgery is too many. Would you not agree? The other thing is make sure that you're widely disseminating your results. Let people know what you're seeing when you're doing observations. How are you doing as a team? The other thing is measuring your outcomes. Wrong site surgeries, other kinds of complications that we know using the checklist tends to impact positively, then bring those forward at every opportunity. Set the standard for transparency. You need to have the tough conversations as a clinical leader, and you need to openly discuss your errors because that's the only way that you get better. There needs to be a culture of openness and the ability for people to feel free to speak up. We need to be able to call each other out on mistakes, omissions, and anytime behavior is not consistent with our values or our policies, folks need to be able to speak up. And what's really important here is to understand that not pointing out an error is really as serious as making the actual error. At SBA, we do a root cause analysis anytime there's a patient harm event. And interestingly enough, one of the things that we hear repeatedly is that I had a gut feeling. I didn't think everything was okay. I wondered about that. And as we push forward in making sure that we have a better culture of patient safety, more transparency, we see that pushing in a better direction. However, if you're hearing those kinds of things, it's a sign that your culture of patient safety has not arrived quite yet, and that you really need to go back and make sure that you are having those tough conversations, and that really the transparency and the ability to speak up is what you're envisioning, because that's what drives to that better culture. And never forget to celebrate your successes. The stories, those are the things that become alive in us and allow us to relate to that next situation. Remember what happened that last time, that last day, and being able to pull that forward to our now patient and being able to make a difference. Talk about your turnaround. Talk about your outcomes and what they're looking like. Talk about the ability and the ease of speaking out if it's improving over time, and really driving consistency. There can't be any lapses or any shortcuts, because those are the things that allow you to lose the foothold and really interfere with the success of your overall implementation. At this time, I'd like to turn it back to Linda for a few closing thoughts.
Thanks, Michelle. So we have shared the latest thinking on checklists, development and usage. We've reviewed the regulations from an accreditation and a licensure point of view in regards to checklist usage. We've talked about checklist development and implementation, and so just a couple of closing thoughts. I think it's important to remember that the more complex a procedure is, the more opportunities there are to make a mistake, and that all the literature is very clear in pointing out that a well-designed checklist will definitely improve outcomes. And I think the key point that is coming across more and more in literature is that customization and validation of your checklist is really necessary to ensure successful implementation. So no matter how expert we are, a checklist is going to be good. And when all is said and done, it really is the right thing for our patients. So thank you very much, and I think we'll turn it over to Kathy to open for questions.
Okay, thank you, Linda and Michelle, for an extremely informative presentation. We're now going to start the Q&A, and for all of you, as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We do have several questions here. I'm just going to fire off the first one for you. Is the Safe Surgical Checklist required for surgical patients only?
Michelle, you want to take that one?
Absolutely. So the Safe Surgery Checklist is required for all procedures that occur. So remember I spoke about the dental cases earlier and the surgical miking. So literally the Safe Surgery Checklist is for all procedures that happen in our setting, including GI, including pain management injections. Make sure that you have a customized tool developed for those service lines.
Okay, thank you. Do I need to use a checklist, or can I just have the components somewhere throughout the chart?
This is Michelle. I'd be happy to take that one. Because we're attesting that we're using a safe surgery checklist, it really is best if you can isolate that into a simple tool that has the 3 different periods that need to be addressed. It allows your team to be more successful. It keeps the list short. It keeps the entire team engaged on that particular process. When you break it up and put it in a variety of different parts of the chart, and what we do recommend is that you eliminate the redundancy and duplication in your processes and to pull those key safety elements into your safe surgery checklist, but they get missed. They get lost in the shuffle. So one tool is really the best approach.
Okay, great. Is the Safe Surgery Checklist a permanent part of the medical record?
At this time, Medicare simply says that you have to use it. But when you begin to pull out pieces to eliminate redundancy and duplication within your medical record, and you put them in the Safe Surgery Checklist, if you don't put that Safe Surgery Checklist into the patient's medical record, some of your documentation elements are going to be lost. And it is a best practice to include that in the patient's medical record.
Okay, thank you. How do you get your surgeon involved with the initial marking when it starts with the anesthesia block and pre-op, and the surgeon, based on timing, is still in the OR doing the prior case? That's a long question.
It is. So you have to go back to your standards and remember that the marking should happen prior to the procedure. So really working with your physician champions and working with your physicians who are working within the center and working out the process that allows them to be most successful. But remember, it shouldn't take very long, and in some situations it has to involve the patient. So that is best done in the pre-op area, and it best meets the standards. So engaging the physicians and having them help you design the process will probably lend to better success.
Okay, thank you. Michelle, does there need to be 2 timeouts for these block cases?
Frequently we do see that there are 2 timeouts for the block cases. One is the injection of the medication or the regional block that's done by the anesthesia provider. But ultimately, the one that meets the requirement is the one that's done with all parts of the OR team, including the physician that'll be doing the procedure, in the procedure room immediately prior to the start of the procedure. And if it's a skin incision, immediately prior to that skin incision.
Okay, thank you. Linda, can the components of the checklist be placed on a whiteboard in the OR suite?
Well, I think that's an interesting question, and it kind of drives back to some of the best practices that Michelle has referenced. You know, this concept of, is it a part of the permanent medical record? You know, does it have to be signed? Can it be put on a whiteboard? I think that the guidance itself, it gives you a lot of latitude in that, and I think the important piece here is that you want to make sure that the steps are being done. You know, from our point of view, we're beginning to see that the best practice is that that we go ahead and make it part of the permanent medical record, and that we do have it be an actual document that is either done from a paper point of view, or if you have an electronic medical record, it becomes embedded in that. So those do seem to be the best practices, and the guidance gives you a little latitude about how you go along with those.
Okay, great. We have time for one more question. What do you recommend that a single specialty center, such as a GI or ophthalmology, use as a safe surgery checklist?
This is Michelle, and I would definitely say that you would want to engage your team, your clinicians, your practitioners in developing that. And there actually are some models out there, some examples. So ASCA has some, AORN has some. So simply looking at those that are unique to your specific single specialty service line and asking the question of, do they work for us? Are they simple? Do they get at patient safety? And what would we add or take away in order to make this customized and usable by our team?
Okay, thank you very much. I want to again thank Linda Lansing and Michelle George for their excellent presentation today, and for all of you who participated. As a reminder, we've had a lot of questions, so our presenters will follow up on questions we did not have the chance to address during today's webinar. And we look forward to having you join us again for future webinars. This will conclude today's program, and have a wonderful afternoon.